We got Dr. Tyler Payne and Dr. Amie Rose talking this morning. Just want to give you a few updates. We'll be in Aniana the 26th, the fourth Wednesday this month. We'll do lectures that morning in skills labs. It'll be me and Dr. White. May have an aircraft out there as well, but we'll be doing airway management, pig crew CPR, some scenarios, and in theory, if I can get the pig trachs, we'll do some surgical airways too. So don't miss that if you're in the area. And remember, Orange Beach next week is the Critical Care Transport Conference. It's a national flight advanced practice paramedic conference in our backyard. If you can get out there, do it. Plus, it's the beach as well. So thank you for smiling. We'll get started. All right. Yes, sir. You're on.
Okay, guys, we're going to talk about some research today. If I can get this hooked on. There we go. That works. Okay, so this is the schedule of events today. We're not going to go into the weeds on research and not specifically talk about any specific research today. More just looking at generalized topics, different types of research, and how you can use research if you're at home and you want to look up a certain article on a certain topic. You know, things to look for, what to look out for, and just how to interpret different clinical studies. So that's really what we'll be going over. We'll talk about what research is, why it's important, different levels of evidence, different study types. We'll go over each one. We'll talk about, you know, different EM, emergency medicine research topics, and why emergency medicine is kind of particular in regards to research compared to some of the other specialties, and how there are challenges and other opportunities associated with that. And then we'll kind of go through just briefly at the end a research article just to look at the different sections of a standard research article and kind of what to look for at home. So why is research important, right? So at the end of the day, we're trying to determine what's truth from fiction, right? We have some question, whether it's treatment of COPD, you know, what's best for that? What's best for treatment of pneumonia? What causes some patients to die from COVID when other patients, you know, do fine and are asymptomatic, right? So that's what research is trying to do. We're trying to look at the underlying cause of things, different treatment modalities, various things. There's really three different types of broad areas of research. There's basic science research. So that's things when you think about people working in labs, working on mice, they're trying to determine the fundamentals of disease processes. So they're really looking at on a cellular level what's going on. So an example would be, you know, in a patient with pneumonia, what is happening on that cellular level that's causing all the inflammation, all the damage, what's causing the patient to be hypoxic. And then a different area would be epidemiologic research, which would be, you know, discovering risk factors to say why do some people get pneumonia, why do some people do worse with pneumonia. Those usually look at observational studies, which will go over all the different types of studies. And then clinical research is the one you'll see most in the medical setting. That's really looking at specific treatments, determining what's going to actually decrease morbidity or mortality, because at the end of the day, that's what we're ultimately looking for. So an example would be, you know, will giving early antibiotics help prevent pneumonia on a certain patient population? Okay, so this is what we're doing, right? So first we're going to go over different types of studies and the levels of evidence. Okay, so this is an important slide. So these are kind of different lists of various studies and evidence quality. So if you start at the bottom, that's going to be the one that has the least evidence for. So you can think about it as a case report. So you have somebody that says, oh yeah, I saw this patient the other day that had pneumonia, we gave them this treatment, and then they write it up as a case report. And there's not a lot of studying involved, there's not a lot of different patients. So that would be kind of the least evidence specific, okay? And then as you go up this chart, you get higher up in evidence, right? So the stronger the evidence. So what I mean by that is, the stronger the evidence, the more likely you are to actually having the right answer for the question that you're asking on the research topic, okay? So don't worry about the individual ones, we'll go over each one. But if you can just kind of remember back to this slide, you have case reports, and then going all the way up to systematic reviews would be your highest level of evidence in regards to research. And this is another way of just kind of showing it. You have your non-human studies at the bottom, like I talked about, where you do bench research and work with non-human studies. You have observational studies would be next up, Interventional studies, so that would be like your randomized controlled trials where you actually implement a intervention to see the outcome. And in the very top, kind of gold standard, you have meta-analyses, okay? We'll go over each one of these, so don't worry about, what each one means at this point. All right, so first up on the tier, we have observational studies. You can see there's 3 different ones under it: cohort studies, case control studies, and cross-sectional studies. So the biggest thing to think about when you're looking at observational studies is it is literally just an observation. It might be in the future, it might be in the past, but you're not looking for, or you can't necessarily tell that you have causation because of something, right? So you might, for an example, we'll talk about the different types, but let's go ahead and go to cohort study. So one of the initial types of an observational study is called a cohort study, okay? So they find a group of people, they follow them over time, and then they measure different outcomes in the group of people. So an example would be you find a group of people, you ask them about their medical problems, and then you track their risk of death over time, okay? So that'd be a cohort study. Now, as you can see, even if you find that some risk factors will increase their chance of getting, say, heart disease in the future, that doesn't necessarily mean that it actually caused it, okay? So that's what I mean by it shows a correlation, but not a causation, okay? And that's really the big downside for observational studies. So you can think about it, when I say that correlation does not equal causation, you can think about it like this. So if you went and looked at the beach during the summer, you can find that there's an increased number of shark attacks during the summer, right? But there's also increased number of popsicles sold in the summer, right? So you could say there's a correlation there. Anytime that you see increased number of popsicles sold, you also see increased number of shark attacks, right? But that obviously doesn't mean that it caused it, right? So that would be an example of correlation, but not causation. That's something important to remember when you're looking at observational studies. All right, so we talked about cohort studies. That's one example of an observational study. There's also case control studies, which compares a group of case and control, 2 different groups of people, and you're looking for the differences in the groups. So an example of this would be that you find people with cardiovascular disease, and then you go back and look at their diets, right? So you say, okay, all these people have this endpoint disease process. Now let's go back and see if we can figure out the reasons or anything that correlates with why they have this disease process. Okay, so this would be a case control study. You're looking at 2 different groups of people. That's why it's called case control. And then the last type of observational studies is a cross-sectional study. This usually is where you collect a large amount of information on a large population of people at one point in time. That's why it's cross-sectional, right? So you look at one point in time and look at the specifics of a particular group of people. So an example would be you might look at diets across different countries, look at the prevalence of disease, and then see if there's a correlation there, right? So all these you can see is you can use large amounts of people. You're not actually doing an intervention, right? It's just observational. You're just going back and trying to determine certain causes of what you're trying to answer. The only other thing I didn't mention is under cohort studies, there's 2 different types of cohort studies you might see when you're reading. There's a retrospective and a prospective, and that just means that you're either going back or you're following people over time, right? So a retrospective cohort study, you're finding a group of people, you're determining their disease process, and then you're going back and seeing what different risk factors may have caused that disease process, okay? So remember, this is kind of lower on the tier. It's good research because you can involve a lot of group of people. You can send out surveys and get a lot of these answers that you need for these type of studies. So it's more easy to do than the interventional studies. It's a lot less time intensive. It's a lot less expensive. So this would be some of the advantages for observational studies. And then we already talked about some of the limitations. Just because you find a correlation in an observational study, that doesn't necessarily mean that it's actually causing what you're looking at, right? Because there's other confounding factors that are not accounted for in observational studies. All right, so again, going back to our kind of hierarchy here, we have observational studies at the bottom. So we're going up now to the next tier of level of evidence. That would be intervention studies, okay? So these are your randomized controlled trials that you'll hear a lot of different companies talk about, especially drug companies. All right, so interventional studies, right? We're actually implementing a intervention over 2 different groups of people usually, and then following them over time and seeing what different outcomes you have, okay? This can provide evidence for cause and effect, so you can find causation with this if the article is done right and you have limited to the best of your ability all the different confounding factors. This is a higher level of evidence than observational studies, as we talked before. Okay, so the gold standard of interventional studies is the randomized controlled trial, okay? So usually what happens is, let's just say, for example, you're looking at a certain drug, right? So you're gonna go out and recruit people. You're going to randomly assign the individuals that you recruit to either the intervention arm or if you're giving a drug modality, the placebo arm, right? It's important that they're randomly assigned. We'll talk about that as we go, but just remember that it's important that they're randomly assigned. And of course, the intervention arm is going to get that specific treatment that you're looking for. They'll follow them over a specific time, and then whatever primary outcome they're looking for, they'll evaluate that at a certain set time point, and then they can go back, and it's really strong evidence that that it's actually caused what you're looking at, okay? The goal when you randomize the patients to each arm is you're trying to have similar patients in both groups, which kind of makes sense, right? You can have some biases if you have one group that, say you're looking at a drug for heart failure and one of your randomized intervention arm group has people that are healthier at baseline than your placebo group, right? That can give you different results. So that's why it's important to randomize to try to get both of your treatment and placebo arms as similar as possible. All right, so we talked about randomization a little bit. This is kind of what I was just saying. You want to have similar patients in your control and your placebo arm, right? And that's just trying to eliminate any confounding factors that will be in the study. And it's important to look for this in RCTs, okay? Also, the placebo group is important, especially if you're looking at medication treatments. I'm sure everybody's heard of the placebo effect. It's a real thing, right? So you're trying to remove that placebo effect from any involvement it may have in your data when you're looking at the intervention arm, okay? So the placebo effects is basically you have an effect theme without intervention, which is different than the known normal, okay? And it's just a psychological entity that happens that you just have to account for, and specifically RCTs. All right, blinding. So blinding is important. Not all RCTs are blinded, but if they are blinded, that increases their kind of evidence level, you could say. They can be either single blinded or double blinded. So single blinded would be the actual individuals in each arm don't know what arm they're in, right? Which makes sense, right? You don't want somebody in the intervention arm knowing that they're in the intervention arm if it's at all possible, because that can psychologically just make them feel better. They'll have better just self-reports of what's going on with the medication. And then even better than that, you'll have double blinded, which is the researcher and the participant are blinded to which arm until after the data comes in, right? So the participant won't know which arm they're in, and the researcher or the whoever analyzes the data at the end of the research won't know specifically who's in which arm until after the data's come in, right? So it eliminates any bias on the front or back end. So limitations to RCTs, you know, they are the gold standard, but they come with limitations. That's why they're not always done as much. They're very costly. You have to follow people over time. The study is only good if you, the people that initially started the study, if you can follow up with them at the end of the study, right? So the more people you have drop out, the less evidence you have for the study. Usually involves smaller sample sizes, so it can be difficult if you're trying to power for a certain statistical significance, which we'll talk about. To get the certain sample size that you're looking for can be difficult with RCT. So this is why they're not done as much as observational studies. All right, so going back to our pyramid hierarchy, you have your non-human studies at the bottom, observational studies, which we talked about. Interventional studies would be your next level up. And in the very top, you have meta-analyses and systematic reviews. So this will be when you hear people talk about like a Cochrane review or something like that, that's looking at a lot of different, usually RCTs, and they'll combine all of them together to come up with a similar summary, okay? So you think about it as a study of studies, right? So a meta-analysis or systematic review, they'll go and look at all the studies done on a particular topic and try to come up with a summary of all of them. But the thing you have to remember with meta-analyses is they're only as good as the data that goes in. So you have to look at which RCTs are actually including to determine how much quality you have in the study. Okay, Cochrane Review is a good one. They do a lot of different things. And a lot of the major papers will come out with systematic reviews every so often. Okay, so talking about EM and EMS research, this just kind of talks about the factors that make EMS and emergency medicine kind of unique in regards to research. There's actually been a lot of good research come out of EM, especially in the last 20 years. If you think about it, we are the front lines, right? So we see a lot of very sick people. We see a lot of time-sensitive disease processes, okay? So that makes us kind of the perfect little area for research. And if you think about it, there's a lot of important things that have come out in medicine as a whole from EM research. So, you know, time-sensitive treatment of heart attacks, whether you need to go to PCI, whether you need to lyse somebody, stroke, shock management with goal-directed therapy and getting early antibiotics and early fluids, okay? So a lot of that research came out of the EM setting. So there's a lot of different areas that emergency medicine, you know, just has a lot of opportunities. This is some other examples of some of the research that's come out of specifically emergency department. So you talked about early goal-directed therapy for sepsis was a big one, percutaneous intervention for STEMIs, antibiotics for open fractures. There's a lot of different things. Okay, so we talked about the different types of research, right? So now we're going to go into a specific article, and we're not going to go into detail in it that much. We're just going to look at it briefly. We're going to look at each segment of the article, because if you start looking at articles, you'll see a lot of them are similar. They have the same components in them. So we'll go over each one and kind of talk about things to look for and how to actually evaluate an article critically. Okay. All right, so bear with me. We're not going to be reading through all this stuff, but I want to hit some highlights here, okay? So title and author information. This is just an article I picked. It was a good article. It came out, I guess, I think it was 2015 and 2016. It looked at bougie first. Y'all may have heard of this. Bougie first versus just ET tube and stylet for difficult intubations, undergoing emergency intubation in an ER. This was a RCT, and we'll kind of go over the different parts of the article. So when you pull up an article like this, you'll of course see the title, authors under it. You'll always see abstract, which is like a summary. A lot of people will just look at the abstract, but you'll miss a lot of stuff if you just look at the abstract. It is important to look at the different methods section of how they completed the study. But this can just give you a summary of kind of what's in the article if you're looking for a particular topic and you don't want to actually read through all the weeds of the research article, you can just look at this and it'll tell you, okay, this is what's in the article, and kind of go further from there. Okay, so there's always an introduction in the first part of a research article. It usually gives some good background information and previous research on the topic that it's going over, right? So in this article, you know, they talked about endotracheal intubation in the emergency department, talked about different risks or different complications you can see with intubations. They talk about why it's important that you have a first pass success rate. You know, why is it important to go and actually get it in on your first time, right? So it talks about complications where if you don't get on the first time, you might have hypoxia, other kind of hypoxic brain injuries, things like that. So this is what the introduction does in the article, right? It gives you background. It gives you, why we're looking at this question and any previous research that's been done on the particular question that you're looking for. Okay, so the next big section in the article is usually called methodology or methods, and this is actually telling you the details of how they perform the trial, right? So you can see the first line, it says randomized controlled trial. So we already know it's pretty high level of evidence. It is randomized because it tells us right here. It tells us when it was done, so September 16th through the 17th. It was in an emergency department, so it's always important to look at where they're doing the research study. Is this pre-hospital field? Is this an ER? Specifically, when you're looking at intubation research, it's always good to see, was this in an ER or was this in an OR with anesthesia, right? There's a lot of research involving intubation with anesthesia, but it's Intubating in the OR is very different than intubating in an emergency department, or even more in the field, right? So it's important to look at those kind of things. It's a level 1 trauma center. It shows you how big the trauma center is. It shows you, this one specifically, it says that intubations were performed by either emergency medicine residents or attending physicians. Okay, they all received extensive education prior to this study, and it just goes more into details. You know, they used direct video laryngoscopes. They did some simulation sessions before during their training, which is good to know. But overall, this section of the article will tell you the specifics of how they performed the study, right? It'll usually say if it was randomized. It'll tell you the different arms, right? It'll tell you intervention arm or placebo arm. This is still part of the methods. So this is usually the most difficult part to read through on articles because it really goes into the weeds of the statistics side of research, right? So this tells you how many patients there were. It tells you how many patients they were trying to recruit so they could get a certain power level. So the power level means that we'll talk about statistical significance in a couple of slides. And why that's important, but it's very important in an article to, when you have a result, to see if it's statistically significant. And you have to have enough subjects in your study to have a certain power. So that's why they talk about that here. And it really just goes into more of the weeds on the various statistics. A lot of articles, if it's a RCT, will give you a table that looks like this. So it'll show each arm. It'll show you the individuals within each arm, right? So you can see there was, 370, 380-ish in each arm. It's important to look at, you can see at the bottom here, some people, so this was the intubation using bougie first, oops, and this was the intubation using stylet. You can actually see how some had to cross over. So some of the ones that were randomized to ET tube and stylet first had to be, you could say, rescued by a bougie after the fact. So it's important to look at there. And again, as we talked about earlier, for randomization, you want the different arms to be as similar as possible, right? So you want them to be similar age, similar comorbidities, and that eliminates a lot of the different confounding factors that you might see in a study, right? So it's good things to look for. Another good thing to look for in this section is specific inclusion and exclusion criteria, right? So there's going to be certain things they're looking for when they're putting patients in a study, right? So this section is still under the methods section, but this tells us what specific subjects they picked out to be in the study. So it was only patients greater than 18 years old, to no kids, right? It was in the ER, which we already talked about. This also talked about what their backup plans were and if they were going to be included in the study, if they had to be rescued by one of the other interventions, or if they had to be rescued by a video laryngoscope. So prisoners were excluded, pregnant patients were excluded. It's also, see, if you can see right here, it says patients with known distortion of the upper airway were excluded, right? So angioedema, epiglottitis, right? Which you would think would be some of the ones that would be more beneficial with bougie, and that's why they excluded them, because they've actually done studies in the past that show this is beneficial, so they kind of weren't looking at that necessarily. So that's why it would be important to look at inclusion criteria to see exactly what subjects they're looking at, to see when you're out in the field and you're trying to think of, different things that might help shape your treatment modalities. You don't want to be looking and say, oh, well, this article said this, but you're actually looking at, say, a kid or something, right? So it's not generalizable to a different population from your inclusion criteria. All right, so the results section is kind of your where they give the primary and secondary outcomes, right? So most all RCTs will have a primary outcome. So that is what their main endpoint is that they're looking. So in this one, they're looking at first attempt pass rate, right, for intubation. There are also some secondary outcomes. So secondary outcomes would be things that they may find in the data afterwards, but it's not necessarily what they were specifically looking for, okay? So things in your secondary outcome are not going to be as highly evidence-based, and that's just because that's not specifically what the article was looking for, okay? That doesn't mean it's necessarily bad data, but it's just not what they're specifically looking for, so it doesn't have the same level of evidence as the primary outcome or primary endpoint would be for a study. So in this article, there were 380 patients, at least one difficult airway characteristic, right? So that's what they were looking at. They were looking at patients that had at least one difficult airway characteristic. They say the first attempt intubation success rate was higher in the bougie group than the ET plus stylet. And then they talk about the absolute difference, and which kind of goes into the statistical significance, which we'll talk about in a minute. But usually this section will just show the summary of the findings, the kind of summarize the data that was previously shown in the article. And then it'll, like I said, talk about some secondary outcomes. So in this one, let's see, what was some of the other secondary outcomes? One of the interesting was, so they were saying that down here at the bottom, you can see that it actually improved first pass success for people that were had to be in C-spine precautions, right? So that wasn't necessarily something they were looking for, but in the data, that's what it showed on one of their secondary or their data analysis. So it's a secondary outcome, but it's not a primary outcome, what they were actually looking for. It was helpful in obese patients and patients with not a complete glottic view when they were going in for a first look. So again, this is a table from the article, which kind of summarizes again the data that shows. So this was first pass success rate for bougie versus just in ET tube and stylet. So you can see here is your number, and this is your, so total out of number of patients. And then here is where you see the p-value, okay? We're going to talk about p-value a little bit because it's important when we're talking about statistical significance, okay? So the p-value is less than 0.001, which is good. We'll kind of explain what all that means, okay? We talked about secondary outcomes, not as evidence-based because it's not what the study was designed for, but it can show you some truth depending on what exactly you're looking at. All right, the very last part of the article is the kind of the meat where it wraps up what the things it was looking for, what it actually found in the data. It talks about what this means for kind of research going into the future. It will usually, you know, kind of give some examples of how they could have done better and some of the limitations of their study. So an important part of the study to look at, to give a summary of everything. Okay, let's talk about statistical significance. Some of y'all, I'm sure, have probably heard of this before. So anytime we're looking at results from a study, in particular RCT or randomized controlled trial, we're looking at to see if it's statistically significant, right? So we may see a difference, right? We may see a difference between the two groups, but there could be a chance that that difference we see is just by random chance, right? So what our whole goal of the study is to try to determine, was the difference just random chance, or was it actually based on the intervention, right? And what tells us that is this statistical significance, okay? So again, it's important to determine if our findings were actually caused by our intervention or if the difference we saw was just based off random chance, right? And how you determine this is determined by a lot of different things, but most importantly, it's based off the power of the study, right? Which is the size and the participants that you have. If you think about it, the more subjects you have in the study, the less chance that that difference you see is actually from random chance, okay? So anytime you see data and it has a, you know, a difference in an intervention versus a placebo arm, it's going to give a p-value, okay? So the p-value is just a percentage. That's not what p stands for, but it's a percentage of what is caused by random chance, right? So the kind of gold standard for research and RCTs is that you want a p-value of less than 0.05, right? So if a p-value is less than 0.05, then that means there's a greater than 95% chance that the results were not caused by random chance, okay? That's kind of weird if you just kind of talk to it, but just think about it, right? So if it's less than 0.05, it's a greater than 95% chance that your results that you saw were actually legit results and not just caused by random chance, okay? Now you can get less p-values than this, like we saw in our study earlier, that was 0.001, right? which is even better. That means there's greater than 99% chance that the results you saw were not just due to random chance, okay? So a lot of people will talk about this, and it's something important to look at when you're looking at a research article. Again, going back to the specific table in the article that we're looking at, you can see the p-value of less than 0.001. Almost all data, when they provide it, will give you a p-value, and that's just based on the power again to see if it's statistically significant. So just kind of putting everything together. So based on what we've read, just say we have a question on, should I use bougie first when I'm intubating somebody that I think may have a difficult airway, right? Because that's what the article was asking. And the question is probably yes. However, maybe, there's some other things to consider, right? So anytime you look at an article, you want to look at, does the question you're specifically asking, is it answered by this research article, right? And that's all the different things that we talked about, the inclusion criteria, the exclusion criteria, the data that it actually shows, is it statistically significant? And can it be applied to what I'm doing out in the field, right? So when we're looking at, say, this specific article, right, we can only extrapolate the data in this article to the specific settings that it was originally done in, right? And that means generalizable, okay? So this study was on difficult airways. It was done by senior residents or attendings. It was done in the ER setting, right? And that's not saying that this data wouldn't be the same if it was done in the pre-hospital setting, but it's just saying we don't know, right? We can't generalize it to that setting. Because this article was done in the ER, okay? So that's why it's important to look at the different study parameters when you're trying to really critically look at an article, okay? Common pitfalls when you're looking at articles, a lot of people when they first start looking at research, they just look at the results section. It's important to look at the methods section because that'll give you an idea of how strong the research is, right? Based off what we've talked about, right? Is it an observational study? Is it a randomized controlled trial? Again, determining if the findings were statistically significant, right? Because it doesn't matter if findings, say there was a 20% difference in the two groups, but the p-value wasn't less than 0.05. That means that it could have just been random chance that those differences were there, not necessarily because caused by your intervention, right? Not looking at disclosures, again, for possible biases. That's commonly in the kind of the drug world. There'll be a lot of RCTs that are put up by the company. So it's just good to keep that in the back of your mind that, hey, there might be some bias there because the company is paying for this. Not necessarily, but it could be. So again, a good study to kind of just keep in your mind when you're looking at research, the different hierarchies. So the top is the best evidence, observational studies, RCTs, interventional studies, and then your systematic reviews at the top. So kind of a lot of stuff all at once, but in summary, the biggest things I want you to take away are observational studies are great. They look at large numbers of people. They look at population studies. Remember that correlation does not equal causation. Just because you see a correlation in a observational study, that doesn't necessarily mean that what they're looking at caused the end result. Double-blinded RCTs are the gold standard of scientific research in regards to interventional studies. Meta-analyses are king, but however, you must remember that they're only as good as the studies that are in them. Try to always look for statistical significance, which I've kind of already talked about. Look for good randomization, so make sure both of the arms of each group are equal and have same characteristics. And remember, the results are only good for the study as what you are specifically looking for, and that's what I talked about with generalization, right? So just because one study says this doesn't necessarily mean that it can be generalized to other settings, right? Doesn't necessarily mean it's not true, but it just means that we don't know, okay? And then always remember to look for inclusion and exclusion criteria as well. Okay, so that was kind of a lot of stuff. Y'all have any specific questions? Any research articles recently y'all looked at and had questions about?
So I've got a couple of things. So that was great. I think that that overview, but I think that probably one of the biggest issues we have in EMS is selecting the article in the first place. And so there's a big difference between trade journal and academic journal. And just so everybody knows, for example, EMS World, GEMS, those are trade journals. Generally, the articles that appear in those journals are not peer reviewed, they're not vetted, and they rarely include experimental data, which means they're essentially opinion. There's nothing wrong with that. Opinion can drive a conversation, can lead to definitive research, but I think it's important, especially if we're going to talk about changing practice based on something we read in a journal. We need to make sure it's peer reviewed. We need to make sure the methods were sound. And like you said, I would like to see a meta-analysis before we change any practice. A study of studies is how I like to describe a meta-analysis. There's also literature reviews, which are kind of a different type of meta-analysis. And in the social sciences world, meta-analysis means review of literature reviews. So literature review is just a review of all the literature that's been published on that particular subject. And oftentimes medical research will have a section after the introduction that will talk about the literature review that the authors of the study did before they designed the research, to explain why they chose the experimental design that they did. But I wish that more folks in EMS would kind of embrace reading the research that's being published in the literature, because it really helps us move the profession forward.
Yeah, and a lot of people, you know, when they start out, they're like, you know, there's so much stuff like that, I just don't know where to start, right? So if you pick a meta-analysis on a certain subject and just read through that, that's a great way to start, because you know it's good evidence, right? It'll show you multiple studies about the topic you're looking at, and you can find them fairly easily if you go on and look on their certain topic. Now, you know, they are studies of studies, so there might not be one on every topic you're looking at. That's the only thing with meta-analysis you got to look at, right? And then, yeah, talking about expert opinion. So that's kind of, you know, kind of anecdotal data. Expert opinion is kind of somewhere down here in the lower part, but sometimes that's all what you have, right? So there can't be a RCT on every single thing you do, right? That's just not possible. So sometimes you have to go off of expert opinion, people that have been in the field for a while, but you just have to realize that data, that evidence is different than a RCT, randomized controlled, where you can actually look at the data that way.
What's the time?
What? No, go ahead.
What's the timeline usually on a study? I know that, I'm sure there's.
Yeah, so it depends on the study. Some of these bigger ones, it could take 3 or 4 years, you know, because they, like this study, I think they did it over 3 years. Sometimes it'll take a year or two to write up and be published somewhere. So it just depends on how big the study is.
We participated in a study here that many of you may not even be aware that we participated in. We participated in a study trying to decide that if we could identify at time of dispatch patients in the field who might possibly benefit from a forward surgical team, trauma patients. And we collected data on that for about a year. It took us about 6 months to write the article, and the peer review process just ended, and that took, I think, almost a year. So the peer review process is really exhaustive. They made us edit a bunch of things. The peer reviewers had a bunch of questions for us. The authors of the research don't know who the peer reviewers are for that particular journal. The journal that's being published in is the Journal of Trauma and Acute Care Surgery, which is an academic journal. Sometimes the peer reviewers are blinded to the author's identity as well. In fact, that's kind of the standard in medical research, not the standard in social sciences. And it's important that that's true, because you have certain physicians and scholars that produce a lot of research and get kind of known for the research. So you don't want the reviewers giving them a pass because they've read the previous stuff. And you also don't want them being extra hard because they've never heard of them before. So that's another blinding process that's important, so that you make sure that what's published is as accurate as it can be. Does that mean that every academic study is valid? No, it doesn't. That's why before we change practice, we should really wait for a meta-analysis level of evidence before we change something that we're doing that might affect patient outcomes. In my opinion, that's what we should do. What do you think, Dr. Ferguson? Is that about where you are on changing practice?
Yeah, I think this is a great overview. It gives you a way to look at some of these papers. So for example, there was the way we look at permissive hypotension and trauma, right? So if somebody's blood pressure is, 9, they might have tachycardic, we don't give as much fluid as we used to 10, 20 years ago, right? And we found out that by giving that fluid, it washed out clotting factors, they do worse. However, if you go back and look at some of those studies, all those studies were done on healthy military young people, right, in shape people. And that's not the patients we take care of in Birmingham, right? The other thing is all those studies excluded people with head injuries. And what usually kills people in blood trauma long-term is head injury stuff. So you gotta be able to look at this data and figure out how to actually apply it and realize that there are limitations to it. So very important to understand these levels of evidence, understanding who is excluded from a study, because that kind of changes the whole overall reach of this as well. So very important stuff. As far as the journals, I do like EMS World and GEMS, don't tell anybody.
I like them too, they're just not up to an academic standard.
Right, so there is one out there, and it's put out by the National Association of EMS Physicians. And these are EMS-related research that is done with physicians, ERs, and EMS agencies. Easy to look at, and what I usually do is I look at that once a month, kind of go through the titles and see if there's something interesting that might be changing the way we practice. And then I'll pull that article out and look at it and kind of go back and apply these principles to say, okay, do I think this is reasonable or not reasonable? And that's how we address that. Here at Centerpoint, we've had a advisory, what was the official name of the council we did it?
Yeah, the scientific
Advisory
committee.
And we would take these things, and that's how we kind of started doing some of this passive oxygenation and pig crew CPR several years ago. So you don't have to understand the super details of all this, because I don't either, but you got to be able to look at an article and say, okay, this makes sense and this may be reasonable versus, okay, this is BS. I don't even look at it.
And some of the journals are surprising. Like Harvard Business Review puts out great articles. It's a very popular journal for business studies. It's not an academic journal. It's not peer reviewed. It's essentially opinion. It doesn't mean you can't get a lot of good information out of it, but we're responsible for taking care of people when they're sick and injured, and the things that we do or fail to do can have an impact on their outcomes. So that's a pretty serious responsibility. So when we change practice or think about amending the way we take care of patients, we have to make sure that we're using information that's been vetted by experts. It's gone through a formal process, so we don't end up hurting people. That's the reason why I think it's so important to recognize. And so, people want to get on Google and just Google stuff, and that's a good starting place. But just because you find an article about COPD on Dr. Oz site or WebMD, that doesn't mean you should change the way you treat COPD patients based on that. You should continue your research to find, there's plenty of academic research about COPD treatment in the pre-hospital setting. There's thousands and thousands of research pieces there that show you what the best practices are. So you just have to not be lazy. You have to keep going and see dig for that information. And it kind of gets fun when you're researching a particular topic. It's kind of like a search that you go on, see a couple of heads nodding, people who have been in school for a long time. At first, it's just drudgery and it seems really boring, but when you really get intensely interested in a topic, I think it's kind of fun. I can get kind of lost in it.
But like you said, when you think about changing practice of things that matter, you got to make sure you're making the right change. Years ago, we changed our epinephrine dosing from low dose to high dose. We thought that was great, and that didn't work out so well. There are new things in cardiac arrest now. Have you ever heard about double defibrillation or dual defibrillation, using 2 monitors, trying to get them out of VFib? There's some new things they're looking at. There's also some people looking at using beta blockers for VTAC or VFib arrest or persistent VFib. So when you start thinking about changing the things that we know kind of help people, you got to be careful. So you got to make sure that research is appropriate before you hurt somebody. Thank you so much, sir.
All right, everybody, we're going to take just a few minutes break, get up and stretch your legs, get some coffee if you need some, and then we're going to come back with Dr. Amie Rose. Everybody, welcome back. We're going to get started with Dr. Amie Rose from UAB. She's going to be talking to us today about abdominal emergencies. So thank you, Dr. Rose.
You're welcome. This one? There we go. So abdominal emergency, this is a big topic. So I'm gonna just try and stick to the high yield stuff. But then again, everybody who calls is an abdominal emergency, right? Just a heads up, this is not traumatic abdominal emergencies. There should be a separate lecture at some point throughout the year. This is more like the medical emergencies. Our good friend, Dr. Joel Evans, will also be covering GI bleed in detail on the 28th. So I'm just going to do a quick intro. I'm going to leave the rest of that up to him. Don't want to steal his thunder. So the big goals are, one, talking about peritonitis, which is mostly the holes in the itis. Talking about acute mesenteric ischemia, GI bleed, just the intro, your liver failure, your bowel obstructions, your AAAs, hernias, torsions, and then big high yield misses that you may think is abdominal, but it's really not. Maybe it is. So the first thing, obviously, differentiating between are they sick or are they not sick? Is this like a 20-year-old female with functional abdominal pain that's like writhing around and screaming? Or is this like a 70-year-old female who's like super frail, cachectic, clammy, pale, not good? So obviously, you want to check them out, undress them, see where they're actually pointing to where their pain is. Are you seeing any kind of scars? Have they had previous surgeries before? Is it big and distended? Do you see any signs of trauma, any cuts, any holes? Auscultation, because we all do that every time, right? Everybody listens to the belly. And then having a feel, just a quick push down. Is it hard? Is it soft? Is there any kind of weird asymmetry with masses? Just a quick little anatomy reminder. So everyone will kind of differentiate it a little bit different. I always think about it like my right upper quadrant, right lower, left upper, left lower, and then it's pretty much like my periumbilical, suprapubic, and epigastric. And the anatomy kind of dictates what your differential is going to be, right? Depending on where they're complaining of the pain is like where the potential problem is. So if I've got my right upper quadrant, kind of what things am I thinking about in there? Just name one. What was that?
Liver.
Gallbladder, liver. Yeah, they're the two big ones, right? Gallbladder and liver, two big ones. You can also have some like referred pain from the back. The kidneys are back there. What about your epigastric region? What do we have in there? Yeah, you can have some diaphragmatic irritation, some gastritis, pancreatitis. Up here in our left upper quadrant, we've got our spleen. That'll be the big one there. And then everywhere else, we've kind of got our gut. So like thinking about colon, thinking about small bowel. And then our suprapubic region, we've got our bladder. And then on the sides, thinking about like ovaries, testicles, kind of hernias, that kind of thing. So this is just kind of a quick little diagram showing kind of what you should be thinking about when you have localized pain. And this is pretty much when you show up and they're like, no, my pain is right here. And we'll talk more about kind of the difference between the types of abdominal pain that you can get. So there's three main types. One is your visceral pain. So this is when you've got some stretching of the fibers that aren't really localized. It kind of processes more in the spinal cord. That's when you get that dull, achy, cramping, like, you've had a bad meal and now you got diarrhea and, you don't really have a focal point that you like, it's right here. That's different to your parietal pain. So that's like when you know exactly where it is, it's processed right at that level. So, think of like your appendicitis, although obviously that can be somewhere else as well, and we'll talk about that in a bit. But they're like, no, I can feel it, it's right here, and they'll point to a spot. And then you've got referred pain. So this is usually like embryologically, when we develop, some of these pain pathways kind of cross, and you can have pain that originates somewhere else, but you perceive it elsewhere. So a big one would be the gallbladder. So some people can complain of right shoulder pain or, left shoulder pain for cardiac issues. So that's like referred pain. So the first thing that I'm going to talk about is peritonitis. So everything in your abdomen is covered by kind of a layer of tissue called your peritoneum. You've got both a visceral and a parietal, and that's kind of the coating of everything. That can get inflamed. And one big thing that I want to talk about during this is I want everybody to just kind of tense their stomach as hard as you can and just press down on it. that's peritonitis. So if you press down real hard and you touch someone's belly and that's what it feels like, that's peritonitis. If you're looking at someone's abdomen and right before you touch them, okay, I can see Ferg back there saying, I don't feel anything. He's like, yeah, I don't feel anything hard anymore. So if you see somebody tensing up, so that's guarding, and then if you push down, and while you're pushing down, they tense up, that's voluntary guarding. So that can give us like a good idea. So if you see me in the ED dropping somebody off and you're like, hey, they're complaining of abdominal pain. If you tell me, hey, I think they're peritonitic, or hey, they've got, you know, bad guarding, that's going to make me think, let me go and see them, like, let me go push on their belly right now. Because otherwise, if you tell me, yeah, they've got abdominal pain, you know, usually I'll be like, hi, my name's, you know, Dr. Rose. What brings you in today? And start the story. Whereas if you tell me, hey, they're peritonitic, I'm immediately going to go over there and push on it and be like, okay, let's get a plain film or something and see what's going on. So, because usually that means bad things. So the itis, this is more your inflammation. Think of pretty much anything in the belly, add an itis, it's a thing. Gastritis, duodenitis, colitis, nephritis, it's a thing. I'm going to talk a little bit about the gallbladder first. So the gallbladder is kind of tucked away underneath the liver. So most people get the right upper quadrant pain. It can obviously be referred like we talked about before. So if you break it down, the chole is more the gallbladder. So anything that starts with chole, you're thinking of like the gallbladder system or the biliary system. And then lithiasis meaning stones. This in and of itself doesn't usually cause issues. People can have it. And not even know that they have it. Like if we checked everybody with an ultrasound in the room, there's probably people in the room that have gallstones and not even know it. The bigger problem comes when it starts to move places. So when those stones kind of migrate out of the gallbladder and they start to get stuck in the ducts, they can cause some discomfort. And then when they start to get inflamed and angry, that's when we start to get problems. So that's when we, you know, if they come in with acute right upper quadrant pain, we get an ultrasound, CT scan, whatever, and it shows a really angry, dilated gallbladder, then we'll usually call the surgery folks. They can just snip that out. The big thing with this is think of the F. This is your risk factors. So those that are overweight are more prone. Females are more prone. Those around the age of 40. Those that are pregnant and those that have pale skin, blonde hair. I've essentially just described myself, but that's fine. My gallbladder's okay for now. The one scary kind of on your differential that I want you to think about with the gallbladder is ascending cholangitis. So what this is that some kind of bacteria in the gut has traveled up the system. So it's kind of gone from in here, kind of traveled back upwards, and these people are really sick. So if you've got right upper quadrant pain, they've still got their gallbladder, they're febrile, they just don't look good, have this on your thought process because they can get really septic really quick.
Would they be vomiting by them?
Potentially, they could, but usually I don't really see people vomiting gallbladder. That's usually more of a downstream, but they could. One thing I do want you to think about in terms of like what their presentation is like is obviously they're going to have the right upper quadrant pain, right? Because that's like where the problem is. So they're going to be jaundiced, and that's more of because of the backflow. Instead of the bile being able to kind of just go out into the digestive tract and kind of being processed as usual and showing up in your poop and your pee, now it's starting to affect the skin. That's when you start to see the yellow kind of eyes, the yellow kind of skin. And then you're going to have the fever because that's part of the infection piece. This is Charcot's triad. Then when you start to get altered and you start to see signs of septic shock, now we're like really getting into like the hairy area. These folks need antibiotics like real quick. You've got someone with pancreatitis, and this is more of like an acute flare of pancreatitis. So this can be a new problem, or people with chronic pancreatitis can have routine flares. They'll usually tell you though, they'll be like, oh no, this is my pancreatitis pain. Causes gallstones. So when you block that one duct kind of going out into the gut, you can have a backflow of fluid into the pancreas. It's not able to kind of drain out as it does, it builds up. Alcohol is a huge one. These are the two big main ones, gallstones and alcohol. So I always ask people, you know, how do you drink? How often are you drinking? They'll be like, oh, not that often. How much? A 6-pack a day. I'm like, yeah. Triglycerides are another one that can cause pancreatitis. Drugs like the sulfastatins, Depakote can do it. There's some other ones as well, but these are usually the big ones that people are on, the more common ones. Viral illnesses like mumps. Trauma can do it. We always get, I don't know why at UAB we get an amylase instead of a lipase. So like when we're getting blood work, we tend to get lipases usually, like the ED folks, but as part of the trauma workup, they get an amylase and not a lipase. It's more specific if you get the lipase for the pancreas. So.
Before we scanned everybody,
Mm-hmm.
Yeah. You go to small bowel too.
Yeah. But since we scanned everybody, I'm like, there's probably not a need for it.
I know, we get A1Cs on people as well. I understand that either.
Yeah, that's good.
And then another thing is the metabolic disorders. So this is more peds. Don't ask me what metabolic disorders. Like I forgot that a long time ago when I was in med school when I never used it. So that's why we have specialists. The big thing with these folks though is that they need fluids. So if you have someone that's coming in with screaming epigastric pain, they're vomiting a lot, obviously it'd be nice to give them some Zofran if you have capabilities to do that, but getting IV access and giving them a little bit of pain control won't usually hurt them. When we have somebody come in and we check their labs and we find out that it is pancreatitis, either on labs or like if we see like the CT scan and it shows like some fluid around the pancreas, we'll usually just like give them a bolus or two, put them on a IV fluid rate if we're not able to get their pain controlled, and get them admitted to the hospital till it dies down a bit. All right, so then we've got our appendix. Everybody loves that. Back in the day, we used to think that this was completely useless. Now there's some more evidence showing that it does actually contribute to our gut immune system and helps keep a healthy microbiome. One thing with this one is that you'll see people that say, hey, I started having like, it started around my belly button and then it kind of went down into my right lower quadrant. That's like a really highly suspicious story for appendicitis. And you'll feel it right over McBurney's point. So you've got your hip bone. I know folks over there trying to feel that as well. And then you've got your belly button and you kind of move kind of a third of the way across from your hip bone or 2/3 from the belly button. And that's usually where it's housed. So you'll press down and people can have pain there. Sometimes people can have pain when you push down on the left, they'll actually feel it on the right. If you pull a patient's leg back, that kind of stretches the muscle right over the appendix and that can cause irritation. These are all just signs that it may potentially be that. These patients are vomiting. These patients also have diarrhea and can have fever, but also may not have any of these. So they all get the donut of truth if it's an acute onset, really bad pain. All right, moving on to mesenteric ischemia. So the gut is mostly supplied by two big vessels off the aorta, the mesenteric arteries, and you can have any kind of blockage that can cause bowel ischemia because that gut is not getting the blood supply that it needs to kind of keep healthy and alive. So the classic thing that they teach us in med school is pain out of proportion to exam. So somebody is screaming, writhing in pain, you press on their belly, it's actually not that bad. They're not peritonitic, you know, you can mash down, you know, and you're like, are they lying? Like, are they just really dramatic? But you need to be really careful, especially in the people that have risk factors. So those that are above the age of 60, those that are prone to any kind of clot. So anyone with AFib that's not on a good blood thinner, or even if they are, people with heart failure, and those people with kidney disease as well. Another thing that can cause it is low volume status. So, you know, think of hemorrhagic shock, septic shock, any kind of like anaphylaxis, anything that's kind of distributive or hypovolemic that can cause some gut ischemia. So keep aware of that. These people also get really sick really quick.
Dr. Rose, can mesenteric ischemia be caused by drugs, like an over-administration of anything that vasoconstricts?
Yes. Anything that could potentially alter the blood supply to the gut can cause it. GI bleed again, just a little in there, July 28th. Dr. Evans is going to cover it. But the big thing is that you can have different types of GI bleed, right? We think of upper, we think of lower. Upper really bad, we're thinking of like bright red blood, vomiting it up, varices, some kind of like really bad gastric bleed. I was always taught like, oh, we need 2 large bore IVs. These people get really sick. And I never really, you know, people would be like, yeah, I vomited. It was a little blood speckled. That's all I had until I had a upper GI bleed, like a real upper GI bleed. And it was this lady I'll never forget. And she was like, yeah, I vomited at home. It was like really bad. And I was like, okay. She looked fine on the monitor. She kept complaining of belly cramping. My belly's cramping so bad. It's so bad. I'm like, all right, okay. But by this time, you know, like she was already in the ED, hooked up to the monitor. She had a history of like some kind of bleeding gastric ulcer. But she looked fine otherwise. She was one of those people that was actually signed out to me. And, you know, when you sign out, she's stable. She's kind of, we're already in the process of getting her admitted, not really thinking about her too much. And then the nurse comes out and she's like, hey, she's really complaining of like belly cramping and she's like really nauseous. So I went in there. As I walked in, honestly, it was like 2 liters of just blood all over the floor. Immediately went up to the 140s, 150s, immediately was like 70s over 30s. And then I was like, okay, well, this is what I understand now. So she immediately went for endoscopy where they, you know, reached the source of the problem and clipped it, and she was doing fine. But I'll never forget that, because you can have these small little upper GI bleeds that's like, you know, a little tear or a scratch or something. And when you get the really bad ones, you get the really bad ones. Upper GI bleed can also present in the stool as well. So that's when you have people that have like the black stool or, you know, the really dark red stool. Or you can have something a little bit more scary, and that's like the bright red blood. And that's when you start to get, you know, like a lot of bright red blood. You can have huge clots in it. And these people can also get really sick. But again, Dr. Evans will go into more detail about that. Next month, July. Big thing with these guys is access. Really 2 large bore IVs. Get some fluids going.
Do you recommend like blood pressure is low, using TXA for?
I don't think we're doing TXA for lower GI bleeds.
So good question. So there was actually a study, a research done that kind of looked at TXA for GI bleeds, and it showed that they had worse outcomes long-term if you gave them TXA. However, they kind of pulled people together. They had people that had GI bleeds that were less than 3 hours in duration, and a whole bunch that were greater than 3 hours in duration. And we don't use TXA after 3 hours in trauma because there's some risk. So I think that the outcome is kind of skewed by the people that they looked at. So short version, if you got somebody that's got a GI bleed and is crumping, it's category B, but I would use TXA. Did I really confuse you there?
No, sir.
Okay.
I'll just call ahead of time. So.
Yeah. So I think the TXA is reasonable in somebody that's symptomatic of a GI bleed. Yeah.
I love how it was like it was unintentionally planned that he was going to do his research presentation before, and it just lined up perfectly.
Good. I'll give you a cash register.
All right, so liver failure patients, so these are really sick people. I always hate when a really sick liver patient comes in because you just never know how quick it's going to decline. So obviously you show up on scene, they already know. If they're looking like this, most of the time they know that there's something up with their liver. It's like alcohol, it's hepatitis C, it's something. But you usually see this big old like Goomba of a belly, and that can kind of clue you in to be like, oh, hey, the yellow of the skin plus this. All right, well, you know, we could probably have some badness going on in there. Other signs is you can have signs of portal hypertension. So that's when, you know, the pressure in the liver blood system is kind of backing up and it starts to backflow into the abdominal wall. So this is your caput medusae. And then you can also have these non-specific signs. So this is not, if you see this, this could be also caused by other pathologies, but the ring around the belly button is Cullen's sign, and then you've got your Gray Turner, which is just kind of like bruising on the flanks. That can also clue you in that there could be a component of portal hypertension as well. The big thing here is that that big old Goomba of a belly is essentially just fluid, because what's happening here is you've got your liver. Your liver is responsible for like processing proteins, specifically your albumin. And your albumin is responsible for keeping fluid in the vessels. So that's your oncotic pressure. It pulls everything in. When you start to have low protein in the blood, you don't have anything to hold the water in anymore. It starts to leak out. And that's what is happening when you see that big old belly, and that's your ascites, so you're getting the fluid in the belly. Usually, if you've got someone that has low blood pressure, because these liver folks usually do have low blood pressure, your first thought, you know, when they're really sick looking, or if they have low pressure, is to give them fluids. I would really be really cautious on these folks, because essentially any fluids that you give them, whether it's LR or normal saline, just think of it as adding to the belly. Like, it'll improve your numbers, you know, enough for you to drop them off. But it's like, if you don't have any protein in the vessels to hold it, you know, in there, it's just going to leak back out. The numbers are going to start to trend down. So you're essentially just treating a number and not really, you know, helping treat the problem. But sometimes you don't have a choice. You know, if they're actually clinically affected by it, then you got to do what you got to do. But usually we'll start with giving them some albumin to see if we can kind of pull some of that fluid back in to help their pressure. Another thing with these guys is that they tend to bleed. So the liver, again, fantastic thing, helps with metabolism, all that good stuff. Helps with TPO, so that's your little platelet production kind of helper. And then it also deals with a lot of your production of your clotting factors. And that's important in both primary and secondary hemostasis. So when you've got dysfunction of both, then it can cause issues. Bowel obstructions. Many different things can cause it. The big things we think about is adhesions. So anybody who's had any kind of prior surgery before, anything that's kind of irritated or like traumatized the intra-abdominal area has the potential to cause adhesions. Sometimes poor diet can do it. Malignancy is a big one, like the colon cancers. Volvular, so where the bowel is twisting on itself, foreign bodies, hernias, just to name a few. There are other sources. But that leads me into hernias. So you can get hernias in a lot of places. If you have somebody and they're complaining of pain at their hernia site, you're able to push it back down very easily. I really don't care that much about it, like in the ED. Like, I'll give them pain control. You know, it's like, sorry, sir, that sucks. You need to go see a general surgeon outpatient. My problem is when I can't get it back in and they're having pain there. So anytime it gets stuck in the hole, and then when you start to see the vascular supply starting to be affected, so it's strangulated, then that's a surgical emergency that we need to get fixed straight away. On your exam, you're going to see it, and you're going to start to see some overlying skin changes. So they can be like red, it can be purple. You can push down, try and poke it in. They're just not going to have it. Some people can have like chronic hernias that they just push in, and you know, they're like, you know, usually I'm just able to push it back in, no problem. What you could do if you wanted to try it, like if they didn't want to come in, is you can actually put them in T-bug and give them a bit of pain control, and they can actually just kind of figure it out themselves. They know kind of how to maneuver their own hernia, which sounds really weird, but you just got to kind of give them a little bit of help with the pain control, let gravity do its thing, and just give them 10 minutes in the room. AAAs. So anybody old with belly pain, you need to be thinking about this, especially those that are males, those that are smokers. What guys tend to get it in those with high blood pressure. So usually a normal aorta is about, you know, less than 3 centimeters. On a thin dude, you may be able to palpate it, you'll feel it. When you have like a rapid expansion and it's causing like belly pain, kind of not really localized anywhere, and they're not really feeling that great, you've got to have this on your differential. Make sure you have IV access in these guys. I wouldn't recommend if somebody's having like, you know, all the risk factors with the really bad kind of suspicion for it, you know, don't push too hard down on there. Just see if you can kind of localize it. If you can't, don't worry too much about it. And then people can rupture. So some people will come in really sick. It does have really high mortality, up to 90%. I've had people where it's just been like, yeah, I've got a bit of abdominal pain. We get CT scan. It's like, oh my God, there's leaking right around the aisle. No, what? I wasn't expecting that. But either way, just something to think about, because obviously if it goes from just expanded, you always think of it like a balloon. So when you blow a balloon, the walls get a lot thinner. It's the same thing that happens with the vessel. So gets bigger, gets thinner, more prone to rupture. Rupture's bad. Get some access, get some fluids. You can also get these signs with a ruptured AAA as well. All right, are we still hanging in there, everyone? Getting short of breath, man, this pregnancy's killing me. All right, so torsion, anytime you have somebody that has acute onset, kind of either right lower quadrant, left lower quadrant pain, pain in the groin, think of torsion as a potential problem. So that's whenever you've got either your ovaries or testicles and they've twisted, the blood supply is cut off and now it's starting to die. You can have intermittent torsion. So that's like, oh, I've got this really excruciating 10 out of 10 pain. Then it kind of goes away. So people can intermittently torse. But you want to, this is something that you really don't want to miss, especially in the young folks, because it can affect fertility as well. Things that put people at risk for it is in women, especially history of like ovarian cysts or like teratomas, anything kind of weird that can enlarge the ovary and kind of make it more prone to heavy weight and twisting. And the same thing with guys, if you've got like a varicocele or a hydrocele, any kind of swelling, mumps can do it, put you at increased risk of torsion. Here is a picture in the OR from when they did a laparoscopy. So you can see it's really good and twisted there. Another thing to think about in young women of productive age is ectopic pregnancies. They also usually have localized acute onset abdominal pain. They may or may not have already found out that they're pregnant. They may tell you like, hey, I had a positive pregnancy test, 3 days ago, 4 days ago, whatever. They can be hypotensive, especially if it's a ruptured ectopic, and they can usually get pretty sick. We'll get them in, get an ultrasound, have the OB folks come and take them to an OR. Usually they go in, fix the problem, and actually probably send them home the same day or the next day. Quick, easy fix. And did you know that you could grow babies in the liver? So that's a real thing. There was a lady in India that did it, and apparently there's somebody in South Africa who did it as well. I don't know.
There was a topic in the UAB last summer that was 34 weeks, and it was attached partially to the uterus, the placenta was, and partially to the liver and small bowel. So it's really, really, really rare.
That's
but
amazing.
But it's, yeah, I've seen there's been 5 cases in this state.
Can you imagine doing a fast on that?
Yeah, you get a crowd around you. People want to come see
That'd be
you.
awesome.
Submit it.
So the thing is that it really depends on where the placenta kind of attaches. So especially when you have something that's as vascular and well supplied as the liver, like that just also makes it the perfect setup the same way that it would like the endometrial lining. So it's a thing. And then the last thing that I wanted to talk about is the high yield misses. So you have somebody that comes in, they've got belly pain, epigastric pain, lower quadrant pain, back pain, all that kind of good stuff. First one is a STEMI. Anytime you have somebody come in and they've got abdominal pain, especially like epigastric, right upper quadrant, left upper quadrant, they've got risk factors for it, we'll always get an EKG just to be safe, because you don't want that. You don't want to put your blinders on and be like, they can tell me it's abdominal pain. It's got to be abdominal pain. And then you miss a STEMI. So just something to think about, in your old folks that have epigastric pain, I would grab a 12 lead on them just to make sure that you're not missing anything. Bullets. There's been a few times even in the trauma bay where we've had people come in and it looks like a scratch. We'll get like a pelvic film, because you know how we always get like a chest and pelvis film before we send them to CT just to make sure. But oh my God, there's a bullet there. Like it's happened once or twice. So just always try and strip them down, just take a look, make sure that you're not missing anything. Potentially bad. KA. So people who say, I got really bad belly problems, especially if they're breathing kind of weird, they've had some nausea, vomiting, they've had some diarrhea, they've got a history of sugar problems, either type 1 or type 2. Just always just check a sugar on them and just kind of see what they're doing, because you can be fooled into thinking that this is like gastritis or, you know, maybe appendix or whatever. And then we check that sugar and it's like 1200, or if it's like a type 1, then it's like 500 with a gap or whatever. Most pulmonary infarcts, bad pneumonias, anything kind of lung can sometimes feel like upper quadrant abdominal pain. Just something to consider, just listening to the breath sounds, especially if they're having some shortness of breath along with the abdominal pain. Sometimes it's like, I'm short of breath because of my pain. Sometimes they're short of breath because they're pregnant and giving a presentation, but that's fine. Again, it's almost over. And then sepsis. So never forget sepsis, always on the differential for any kind of complaint that comes in, especially those that have big heart rates, especially those that have low blood pressures, especially those that have fevers. Sepsis, sepsis, sepsis. If they're not contraindicated and you think that they need the fluid, then access an Alita and we'll take care of the rest. And I think that's it. And then obviously the last one that I'm going to just like plug is pregnancy, especially in obese like females that potentially know, potentially don't know. If they're having intermittent sharp pain, always have it on your differential. If they're feeling pressure down below, please take a look. You may find a head. That's all I got. You may find a head. Or you may not. You may find a foreign object. Who knows?
Thanks, Dr. Rose. That was great. I do have a couple of questions for you. So one is, what common medications might be affected by liver dysfunction? So a patient with severe liver disease, what medication do we carry that might have a different function for those patients? Pain medicine was the specific question.
Pain medicine. I don't really think any big ones. Obviously, like if you've got someone in really bad acute liver failure, you don't want to give them Tylenol. Like that makes sense. But if you've got someone that has mild liver dysfunction, you can still give Tylenol. Like you still give the 650 or 975 if they're febrile and they need it. If they're like super tachycardic, they're having symptoms from it, you think they would benefit. Obviously, if it's like an acute toxic Tylenol ingestion and they're hypothermic from it, probably want to give them Tylenol for that. Probably a bad idea. But the rest of them, like fentanyl, should be fine. Morphine with stable kidney disease. I don't know if that's carried on the truck. Obviously, NSAIDs we stay away, but that's more kidney disease. But the only one I can really think of is probably the Tylenol. In the trucks, anyway.
Yeah, so the next question was really for all the physicians in the room was, so certainly in the past, abdominal pain was frequently misdiagnosed in emergency departments and by gastroenterologists. So do we think that the increased use of scanners has improved that? Or are we still finding a lot of difficulty giving definitive diagnosis for abdominal pain?
I mean, if there's something really bad, we're going to see it. But there's still plenty of people that come through the ED that were just like, sorry, we don't have an answer. You've got normal labs and normal CT scan, and if you can tolerate PO, we're going to have you follow outpatient, unless it's really bad and we have to bring them in for intractable abdominal pain. But there's still plenty of people that come in and we don't find a cause for it. But usually if it's like the big bad scary, there's a sign somewhere, either a lab derangement, vitals, CT, ultrasound, STEMI on the EKG.
Yeah, the goal of the ER is to rule out big bad things that kill people or can hurt you in the short term future, right? So like she said, a lot of things we can't figure out. You could be having biliary colic where you have gallstones that when your gallbladder contracts, it rolls around and hurts like a freaking bear, but it doesn't obstruct your duct and get you jaundiced. It doesn't get infected, doesn't cause a white count. It still hurts, but it's not going to kill you. And a lot of times we can't find that out in the ER. So our goal is to keep people alive and prevent them from dying in the near future. So yes, belly pain can be very complicated. Constipation, your Mexican dinner from Moe's yesterday, those things can cause belly pain too, but it's not going to kill you.
Well.
Okay.
And I did actually just think about your question about the like biliary emesis. And one thing that I should have talked about in here, which I didn't, is volvulus. So anytime like we've got a gut that kind of twists on itself and causes an obstruction, anything that's past that duct, that's going to cause backflow. Like if you've got free flowing bile into the gut, but you've got nothing, you've got a blockage downstream and it's just going to come back up, then you'll start to see the biliary emesis there.
Yeah. Or bad small bowel obstruction. So, we talk a lot of times in here about risk stratification, the our history, the questions we ask kind of make you think more at risk for heart attacks or things like that. So risk factors for belly pain would be, have you ever had surgery in your gut before? Abdominal surgery. That opens them up to getting adhesions and having small bowel obstructions. So they're at higher risk for having a bad outcome with their belly pain, so to speak. Other things like a volvulus or something really bad, you think about if somebody's ever had gastric bypass surgery, that's a pretty significant surgery. Those guys are at high risk for having a volvulus or mesenteric ischemia or bowel obstruction. So those guys that come into the ER with me, they have belly pain like that, they get the gamut. They get a bunch of labs and they get, she said, the donut of truth, the CAT scan. Not everybody gets a CAT scan, but that person would get it because they're high risk. So you can risk stratify those people. People who have AFib are at risk for throwing strokes, right? Having blood clots in the brain. They're the same folks that are at risk for having blood clots go to the gut and get mesenteric ischemia. So somebody with AFib and has severe abdominal pain, but you mash on the belly and it's nice and soft, you think this doesn't make sense. You think mesenteric ischemia because they have a risk for it. Now they got the signs of it. If that makes sense.
So this audience seems to be somewhat fixated on the testicular torsion issue. So we have a couple people asking, can adults get that, or isn't that just for kids? So is that a kid thing, or can grown people get it?
All of the above.
All of the above.
Yes.
Oh, you're not helping.
If you have testicles, you can get it.
Oh, well.
Yeah. If we usually they do say like if you've got torsion, you open the book. You just,
So in reality, the classic case that you see in a written exam will be a young male who has acute onset of scrotal pain, or the person that was the young female doing gymnastics or on a trampoline will get an ovarian torsion from that. So that's the classical finding. I think testicular torsion is usually young guys, teenagers, or it's older males who have a testicular cancer they don't know about, and that extra weight makes it torse. For females, the classic one is the young females we mentioned. The other ones are ladies who have a history of ovarian cysts or ovarian cancer. That makes the ovaries bigger and they can move around and twist around easier. So those are the high-risk people for ovarian torsions.
Very good. Hopefully that answered our inquiring minds in the audience. Yeah, it's funny what subjects people focus on.
No comment. No comment.
How common is that? So how many cases a year in the ED?
I feel like I see a lot more ovarian torsion than I do testicular for whatever reason.
I think that's gender bias, because I think I see more testicular torsion than ovarian torsion. You just notice.
Maybe it's like, it's a subconscious thing
It's a
that we sign up for.
Yes.
I'd much rather see an ovarian torsion than I would a testicular torsion.
Yeah.
So.
I see 6 or 8 a year, I would say, in the ER. So
Oh, that's too many. That's too many.
it's too many.
Yeah.
The thing is, with either one, they have to present to the hospital soon, because imagine the blood supply to any part of your body being cut off, all right? So you don't have long. So the rule of thumb for testicular ovarian torsion is about 3 hours. So you have to have a high index of suspicion in the ER, then you have to get the right imaging and test to figure it out, to get them to a surgeon to fix that. Over 3 or 4 hours, you're talking about losing that part of your body, which is not good for young folks or old folks.
All right. Well, if we don't have any more questions.
Would you go change the slides back to the peritoneal fluid? We got a couple of seconds if that's okay.
Sure.
So she talked about the extra fluid, the ascites. So you guys will transport people that have been to the hospital. Folks who have bad liver disease will go and this fluid build up, and every couple of days, couple of weeks, they get this fluid drawn off.
So we put a big catheter in there, drain that fluid off, they feel better, they do well. Sometimes you'll come to these people's house after that, because now they're altered and hypotensive. Imagine you pull all this fluid off, and the only fluid they have left in the body is in the vascular bed. Now that fluid is going to switch and move to the peritoneal cavity. So sometimes these people get pretty hypotensive pretty quick, and they don't have a lot of volume. So that would be the exception to the rule for your liver patients. If they just had a paracentesis and they said, yeah, they took 10 liters of fluid off my belly to make me feel better yesterday, and now their heart rate's 140, the blood pressure is 90, they're hypovolemic. So you would give them fluid, and yes, over the course of a couple hours, it's going to go back in their gut. But for the first little time, while you have them and when I have them, they get IV fluids. At the hospital, I'll give them albumin, which is a protein that stays in the blood and keeps the fluid from going from the vascular bed to the gut. But if they're hypotensive, tachycardic, their volume down, they got to get some fluid on those people. So you'll see that.
And it can also get infected as well, which is what SBP is. So like with them not having the protein in the blood, the bowel can get really edematous, and that can cause transmigration from the bacteria in the gut into that fluid. So sepsis, also think about that.
Correct. So it'll be a mixed picture. So you got a guy who's had a recent tube in his belly to get fluid off, who's high risk for infection, who also got all this fluid pulled off, that's now hypotensive and tachycardic. So your mind is thinking, okay, he's volume down, but he could be septic as well. So aggressive fluid resuscitation, if you have access to push dose epi, that's a reasonable drug for this guy as well. Till you get to the hospital, we can do other things and help determine, is it volume related? Because we can use an ultrasound to look at his vascular bed to see if he's volume down, or if it's sepsis. So liver patients can be very sick. The liver also makes proteins that help in blood clotting. So a guy who has bad liver disease and ascites and trips and falls and hits his head on the floor, okay, which you wouldn't think is a big fall for these folks, fall from standing, that can be pretty bad for those guys. They can have subdural issues like that pretty quick. So liver disease is bad, long-term liver disease. So question, what three reasons are the biggest cause of liver failure in the U.S.? Anybody know?
Jack Daniels.
I would say Busch Light is probably more, but yes, I like that. What else? Anybody know?
Cancer.
Yeah, kind of. So you get hepatitis, and you get hepatitis B or C. It's a big risk to get a liver cancer. That's not good. We can treat hep C right now, so hep C is easy to treat. You can prevent hep B with immunization, so something you may not think about. So diabetes and obesity will cause fatty liver, and then fatty livers end up getting cirrhotic, and people can get cirrhosis and bad liver failure just from poor diet, obesity, and type 2 diabetes. That's very, very common. The other thing that we see is people who take too much Tylenol. So Tylenol overdoses kill the liver, and the problem is if they don't tell us they've been taking the Tylenol, we don't think about it until 4 or 5 days later, and then it's too late. Then we can't fix the problem. So, all right, good. Only 2 people nodded off. I like this. Yes, sir.
Would you rather shy away from giving pain medication for abdominal pain, since like the assessment portion is kind of like the most important as far as the ED goes?
Right. So old school was you didn't give pain management to abdominal pain until the surgeon lays hand on them to determine what's going on. That's kind of going away now because we can scan people and do other things to see if they have a surgical emergency. I would still don't recommend a lot of pain medications for abdominal pain, and unless they look like they're really uncomfortable. If they're playing Panda Pop on their phone and their pain they say is 10 out of 10, they probably don't need control, right? If they're vomiting and flopping around on the floor of their house, they need pain management. So I'd say use common sense there. So
we do have another question about peritonitis. How frequently do you see peritonitis, and how deadly is it these days?
All the time.
all the time, it's pretty common, yeah. So it's more common than you think, especially in the high risk populations that we see at the university center, the dialysis, peritoneal dialysis, immunocompromised, people who've had surgeries in the past, the liver patients. So the key is you have to recognize it.
And sometimes like our GI folks will say that even somebody that has a history of like any kind of liver failure, that come in altered, that's also a sign of SBP specifically. So just to have it on the differential like a peritonitic exam, Still common, but obviously it's different from peritonitis, from like a liver bacterial infection source.
And I see more people who will probably have a peritonitic exam-ish than have peritonitis, because sometimes it's hard to get an honest evaluation of pain. Everybody's pain is different. So you have one person who has pain, their belly is nice and soft, but if you touch them, they scream and spit at you, versus somebody else who is stoic, who has a rigid belly, and like, yeah, it's kind of uncomfortable. So sometimes it's tough to get that exam. It takes a lot. You got to mash in a lot of bellies, see a lot of CT scans, ultrasounds to figure out which is which, and that's tough to do for anybody. Cool. All right, so I'm giving out an EMS challenge cord because you asked questions. Thank you, sir. Very good. I'll give out cash too, but Chief Ward won't give me any cash to give.
We have another question that's come in. Can you discuss, and I don't know if I'm going to pronounce this correctly, mesenteric reflex?
No.
G-R-E-M-A-S-T-E-R-I-C.
No.
Okay, so the answer is no, we can't discuss that.
I will not discuss that. I would say that it has limited use in clinical exam. So your history and the complaint should lead you to think testicular torsion, but Google that one. I'm not going to discuss that one.
Okay, all right. And they're asking for the slide to be put back up that has the quadrants with the complaints per quadrant, so.
Going. Right, that was.
So there you go. There's that slide for those asking for it. And I guess in the absence of any other questions, that's all we've got. Thanks so much, Dr. Payne, Dr. Rose, great lectures as always, and Dr. Ferguson. Please remember to fill out an attendance form for each participant. The link for the attendance form is in the Q&A section. If you don't have access to that, you can send an email to alabamaemschallenge@gmail.com. You'll get an automated reply with a link to the attendance form. The password for the attendance form is IRB, which stands for, Dr. Payne? Institutional Review Board. Yeah.
Sure, one of
As
those.
a reference to our research section, IRB is the password. All right.
Donald thing.
There you go. That's it for today. Thanks, everybody. See you next time.